Subarachnoid hemorrhages come out a lot like meningitis. Subarachnoid hemorrhage comes out a lot like meningitis. Subarachnoid hemorrhage and meningitis. They both give stiff neck. Stiff neck. They both give you a stiffy. They both give you a photophobia. Bright lights, burnt my eye. What would I do if I had photophobia? I'd be out of business. Stiff neck, photophobia, Kernig's and Brzezinski's, although I still can't remember which one is which, because it doesn't matter. Stiff neck, photophobia, Kernig's and Brzezinski sign. Headache, of course. Primordial thing with headache. Well, then again, headache, man. Headache also can come out with pseudotumor cerebri. How do I know it's not pseudotumor cerebri? Well, pseudotumor cerebri, first of all, gives papilledema. Not that anybody can look at an eye exam anyway. Okay. Oh, the CT scan would be negative. Well, the CT scan would be negative in meningitis. Well, pseudotumor cerebri gives an increased opening pressure. Well, all of them give an increased opening pressure. But the difference is this is a severe headache with papilledema and high pressure. Pseudotumor cerebri. Also, the sixth cranial nerve palsy, the abducens. The abducens palsy is common with pseudotumor cerebri, and you treat it with acetazolamide, which is a drug that blocks the production of the cerebrospinal fluid. And if that doesn't work, ventriculoperitoneal shunting. Om shanti, om shanti, om shanti, om shanti. My mom. Did you know that some people, though, with subarachnoid hemorrhages also get ventriculoperitoneal shunting if they get hydrocephalus? And some people with meningitis too. So ventriculoperitoneal shunting can be common to all of them if you start to get hydrocephalus with subarachnoid or meningitis. What's different about pseudotumor cerebri is you can actually fenestrate, slice the optic nerve to drain out cerebrospinal fluid through the optic nerve. You could drain cerebrospinal fluid out through the optic nerve? Holy gogoli, holy moly gogoli, man. Wow. Yeah. So you can see that headache, headache, headache. Negative CT. So what's going to tell you it's subarachnoid? And when you ask medical students and even interns this question, how will you tell it's subarachnoid hemorrhage? The most common answer, incorrectly, is to say the lumbar puncture. And people don't even know. What do you mean, though? Of course it's correct there. The lumbar puncture will be different. Why is that a wrong answer? Because you shouldn't have to do a lumbar puncture in a subarachnoid hemorrhage. You shouldn't have to do it. So me saying, how do you know the difference between these three things? And you say the lumbar puncture. This is like saying, how do you make the diagnosis of my illness? And you tell me autopsy. And I go, yes, it's true. You can make the diagnosis in autopsy, but I really wish you wouldn't. So how do you make the diagnosis? And the answer is the difference between subarachnoid hemorrhage, meningitis, and pseudotumor cerebri is a couple of things. Number one is subarachnoid hemorrhage is very sudden because it's a rupture of an aneurysm and it happens all of a sudden. And even there, the wrong answer is still that it happens from hypertension, that it happens from smoking, that it happens from sex, it happens, no, it just happens. One, it's very sudden. Two, 50% of people have a loss of consciousness. So the most frequently asked question on your test is, what's the most likely diagnosis? So if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. Ooh. If they want you to know that it's a subarachnoid hemorrhage, then they've got to tell you it's instant and we lost consciousness. Other than that, how would you know it wasn't meningitis? If they don't give you the time frame, how would you know? Fever, headache, stiff neck, photophobia, Kernig's and Brzezinski's? That's both of them. But loss of consciousness tells you. The loss of consciousness tells you because it's a big, sudden increase in the intracranial pressure, and that sudden increase in intracranial pressure results in a loss of consciousness. Now, the meningitis, you don't need a CT first either. You need a CT here first only if you have focal neurologic deficits, or if you have severe confusion, or you have some papilledema. That's when you need the CT scan first. So you shouldn't need to do the CT scan for meningitis in most cases. Subarachnoid hemorrhage looks like the sudden onset of meningitis with loss of consciousness. Subarachnoid hemorrhage looks like the sudden onset of meningitis with loss of consciousness. And the CT scan should be positive in 95% of cases. The CT scan should be 95% sensitive. The CT scan should be 95% sensitive in a subarachnoid hemorrhage. You should be able to see that blood. Now, for the 5% that are falsely negative, 5% on the first day, that false negative rate increases with each subsequent day because blood starts to hemolyze. For the people who are falsely negative, this is when you go to lumbar puncture. That's how you'll know to see all the red cells that don't clear from tube 1 to tube 4, from tube 1 to tube 4, from tube 1 to tube 4, from tube 1 to tube 4. It doesn't clear. Same number of high number of red cells, high number of red cells, high number of red cells. Xanthochromia, which is basically bilirubin in your cerebrospinal fluid. Xanthochromia, which is bilirubin in your cerebrospinal fluid. Xanthochromia and high number of red cells. And the other thing, how do you know that it's not just a lot of blood and white cells and meningitis? Because blood, you should only have one white blood cell for every 500 or 1,000 red blood cells. If you have significantly more than that ratio, it's an infection. You want to know how to get in the top 10% of your test, it's questions like this. Questions like this that say, how do you know whether it's infection or just blood? And the answer is infections give a much higher white cell count out of proportion. The infections give a white cell count out of proportion to the number of red cells. Because remember, normally there should not be more than one white cell for every 500 to 1,000 reds. One white cell for every 500 to 1,000 red cells. And if it's more than that, it's an infection. That's a 90th percentile question. Oh, well, the other parts about subarachnoid hemorrhage are kind of straightforward. Now, for subarachnoid hemorrhage, we use nimodipine, which is a calcium channel blocker. We use nipodipine, which is a calcium channel blocker, to prevent stroke. Because one of the things we know is that when your brain bleeds, it gets a likelihood of causing spasm. When your brain bleeds, it has a high likelihood of causing a spasm. And what ends up happening is that spasm after it bleeds leads to stroke. Nimodipine prevents that stroke. Number two is we get in there with angiography, because the angiography tells us where to go in and embolize off that person's bleeding site. Clipping is the wrong answer, because why clip? Why crack through people's skulls, lift up their scalp, crack open their skulls like a bowl, lift up their brain, use a circular saw to cut the skull off, and clip? When you embolize. You embolize it off because what we know is half the people who rebleed will die. So you have to get in there and embolize it off by going up into that blood vessel. You go into the blood vessel and you see the site where it bled. And you take a catheter and you get up there and you put in a platinum wire and clog it off. And you use platinum because what's different about platinum than the other metals? Platinum does not oxidize. It doesn't rust. So that's why platinum wires are used, because they get up in your brain and they save your life, and it stays up in there in your head, and it stays up there, and it's like pure and special and fresh, like the first day you first met. And the platinum wire is like the true love, man. He's like the true love. Get up in your head and stay pure and fresh forever. Platinum wires. I know, you want to get one now. Listen, they say to the pure, all things are pure. So if you're romantic, you can see anything as romantic. Platinum wires is a lot better than drilling a hole in my head. And so that's the management of subarachnoid hemorrhages. Sudden onset of meningitis, which looks like the sudden onset of meningitis with loss of consciousness. CT scan, nimodipine, embolize it off. A small number of people need a lumbar puncture. And if you clog up and you end up getting hydrocephalus, you need a ventriculoperitoneal shunt. Now, the last piece of this is sometimes people have a story like a subarachnoid. And they have the sudden onset of meningitis, type headache, fever, stiff neck, photophobia, and the CT scan is negative, and the LP is negative, and you still think that they might have something up in there. This is what happened to Hillary Clinton. Magnetic resonance venography. Hillary Clinton had cerebral vein thrombosis, sinus vein, cerebral sinus vein thrombosis, and it looks like a story like meningitis, but it's more sudden, so therefore it's subarachnoid, but the CT is negative, but the LP is negative. Where's the blood? Where's the blood? Magnetic resonance venography, and then you treat it. It's like a DVT of your head, heparin, warfarin, heparin, and warfarin, also known as Coumadin. A story like a subarachnoid with a negative CT and a negative lumbar puncture, magnetic resonance venography. It's like a head DVT, a clot in your head. I know you probably never heard of it, but now you have. You can't unknow it, can you now?